Sir, we can have ankylosing spondylitis, but she did not have any history of low back ache or morning stiffness. Then she can have SLE, but the negative history kind of rules out SLE. Sir, Sjogren's syndrome might be a possibility. It can be a possibility.
You have not asked negative history of any dryness in the eye.
Yes, sir.
Rule out that part. Most important, of course, are to look at aspects. Next time.
So further going on with the clinical examination, her general physical
So what was your clinical diagnosis at this stage after the history?
So because she is a 66-year-old female, she can be a case of osteoporosis, she can be a case of osteoarthritis, she can be a case of rheumatoid arthritis, she can be a case of ankylosing spondylitis, but we have to further investigate the patient for that. So general physical examination was...
For the knowledge of all of us and residents, can you differentiate what is the difference between osteopenia and osteoporosis?
Sir, osteopenia
How do you
is...
differentiate in a perimenopausal and menopausal?
So in osteopenia, sir, the gross substance of the bone isn't reduced, sir. In osteoporosis, the gross substance of the bone is reduced, so the bone gets a bit weaker. Porosis is more serious. The general physical examination was unremarkable, with no pallor, icterus, cyanosis, clubbing, or lymphadenopathy. Now we go on to the examination. So on inspection of the bilateral knees in the standing position, we have an attitude of stooping forward posture with flexion of bilateral knees, and the knee alignment in the coronal plane is of bilateral genu valgum and the sagittal plane of bilateral flexion deformity. The swelling is globular around bilateral knees. The skin color of the knees is normal with no engorged veins, sinuses and scars. In the supine position, the attitude from the front, we have both hip joints in flexion and the patellas pointing upwards. From the sides, we have a flexion deformity of around 50 degrees in both the knees and flexion at bilateral hip joints. Alignment is of bilateral genu valgum. Swelling is generalized globular. The skin is non-shiny, no scars or sinuses present, and we can appreciate bilateral quadriceps wasting. On palpation of both the knees, we have a mild local rise of temperature on both the knees and a fine crepitus palpable on both the knees. The cross fluctuation test is positive and the trans-illumination test is negative. We have a doughy thickening of the synovium palpable and medial and lateral joint line tenderness. In the right knee, we have a 50 degrees of fixed flexion deformity, which is further flexible up to 80 degrees of flexion. And the left knee, we have a 40 degrees of fixed flexion deformity, further up to 90 degrees. The varus and valgus stress tests were not testable because the patient was in much pain, and the thigh girth on both the sides, 15 centimeters above the joint line, was 46 centimeters. On inspection of bilateral hip joints, it was grossly normal, with normal balance and no swaying to any one side, but visible wasting of quadriceps was visible. In the supine position, the examination was grossly normal, with no loss of creases, dilated veins or discoloration. In palpation of the hip joint, one remarkable finding was anterior joint line tenderness present on the right hip, and rest all signs were grossly normal. From the back, we had no adductor spasm and the Ludloff sign was negative. And for the movements in the right hip, they were terminally restricted and painful, and flexion extension were preserved. For the left hip, we had a normal range of motion. The inspection of the spine was grossly normal with no paraspinal muscle spasm present. For the neurological and vascular status, we did not have any distal sensory or motor deficit. Bilateral dorsalis pedis and posterior tibial artery pulsations were palpable, and we did not have any lymphadenopathy. This is the video of the patient pre-operatively, and this is the attitude with which she walks. So we can appreciate bilateral flexion at the knee joints, flexion at the hip joints, and a stooping forward posture. From our point of view, the differential diagnosis can be broadly divided into 5 categories, that are inflammatory, degenerative, infective, metabolic, and miscellaneous. So to narrow down upon it, the most likely ones can be rheumatoid, ankylosing, osteoarthritis, osteoporosis, or fluorosis. So for further investigating the patient, we ordered the blood investigations, which are as follows. The hemoglobin is 8.3 grams per deciliter. ESR and CRP are markedly raised, ESR being 107, CRP being 82. The hematocrit is reduced, MCV and MCH are also reduced, which might show preponderance to iron deficiency anemia. These are the other blood investigations. And then we ordered radiological investigations, being X-ray of bilateral knee, AP and lateral, X-ray pelvis with both hips, AP view, and X-ray whole spine, AP and lateral. So to further explain it,
again the hand is missing.
is an X-ray of the hand.
If your differential diagnosis includes rheumatoid, you cannot do without examining and investigating the hand. And as a matter of courtesy to our investigative colleagues, we don't order investigations. We ask for investigations or we request investigations.
So I'd like to call upon Dr. Pratya Soni from Radio Diagnosis to further explain.
Good morning, everyone. To start with, we have the X-rays of bilateral knee joint, AP and lateral views. We can see that the bone density is reduced in these X-rays. There is uniform loss of joint space in bilateral knee joints. There are multiple osteophytes. There is a soft tissue swelling around the knee joint. There are some subchondral cysts and sclerosis noted in the knee joint. There is medial deviation of the joint, suggestive of genuvalgum deformity. In the X-ray of the pelvis and bilateral hip joints, AP view, we can see that the right hip joint space is obliterated with irregularities of the acetabular margins and a small femoral head. There are subchondral cysts and sclerosis noted in this joint. There is also reduced joint bone density noted by prominent trabecular markings in the femoral head. In the X-ray of the spine, there are multiple osteophytes peaking of the vertebral bodies. The joint space is reduced and there is reduced bone density. In the X-ray of the cervical spine, we can see that there are multiple osteophytes. The joint space between C5 and C6 is reduced. There is erosion of the vertebral bodies. In the X-ray of bilateral hands, we can see that there is erosion of the proximal interphalangeal joints and the metacarpophalangeal joints. There is erosion of the carpal bones and kylosis between the distal ends of the radius and ulna. There is marked deformity in all the digits with flexion of the proximal distal interphalangeal joints and extension of the proximal interphalangeal joints, suggestive of swan neck deformity. And there is extension at the metacarpophalangeal joint and proximal interphalangeal joint is extended, suggestive of the Botnier's deformity. This is also known as the hitchhiker's thumb deformity.
Can you please explain about the bare areas?
The bare areas are the areas where the cartilage is not present in a joint, and those areas are most commonly affected by the inflammatory synovial fluid, which leads to erosions. These are the bare areas in the joint space, and here in the proximal interphalangeal joints where the cartilage is not present.
Anti-CCP was more than 300 and she had low calcium, 8.2. Vitamin D was also insufficient. So ultimately we have a diagnosis of a neglected case of long-standing rheumatoid arthritis with multiple joint deformities. Mostly this patient might be in stage 3, that is the stage of fibrous ankylosis. So the question arises, how do we proceed with the patient? What do we do with her? Will it be a purely medical management or a medical management plus rehabilitative measures, or medical and surgical management plus rehabilitative measures? So to further discuss the case, I would like to call upon Dr. Gunita from Department of Medicine.
Namaskar everyone. So this patient was referred to us from the orthopedic OPD for further medical management. On general physical examination, PAVA was present, patient was vitally stable.
On systemic examination, as this is a systemic inflammatory disorder, we did a thorough systemic examination which was within the normal limits. The musculoskeletal examination of the hands was done in detail and other joints also. So on the examination was done under the headings of swelling, tenderness, redness, deformity, active and passive movement. After the examination, it was concluded that the thumb joint and the bilateral knee joints were involved, according to which we calculated the DAS 28 score, that is the disease activity score 28, which is calculated in 28 joints. 5.1 indicates high disease activity and less than 2.6 indicates remission. It is calculated in 3 indices, that is the tender joint, swollen joint and ESR. Further, the patient was started on conventional synthetic DMRDs, that is the methotrexate, hydroxychloroquine and folic acid. Hydroxychloroquine fundus examination was done, which was normal. Other DMRDs are biological synthetic DMRDs and target synthetic DMRDs. Glucocorticoids are also used for the treatment and NSAIDs for symptomatic relief. Further, some words about rheumatoid arthritis. Chronic inflammatory disease characterized by symmetric polyarthritis. It is the most common form of chronic inflammatory arthritis. Persistent inflammation leads to articular damage and bone destruction, leading to functional disability. As this is a systemic inflammatory disease, extra-articular manifestations can also be present, like the nodules which are present, which can also be seen in the cardiovascular system, CNS, leading to CNS manifestations, and pericarditis, and nodules in lungs can also lead to pleural effusion. Diagnosis is made by the raised levels of inflammatory markers, that is ESR and CRP, serum anti-citrullinated protein antibody, and RA factor, which can be positive, that is the seropositive rheumatoid arthritis, and negative, that is seronegative rheumatoid arthritis. Serum IgM rheumatoid factor is present in 75% of the patients. It can also be seen in other inflammatory diseases. Anti-CCP, that is cyclocitrullinated protein, has 95% diagnostic specificity. Synovial fluid analysis can also be done, which reveals 500 to 50,000 WBCs, with most majorly being neutrophils, as opposed to 2,000, which is seen in osteoarthritis. Joint imaging can also be done like X-ray, MRI. Treatment recommendations are given by EULAR. The treatment is aimed at target sustained remission. Monitoring is done every 1 to 3 months. If no improvement in 3 months, or the patient, or we have not reached the target remission within 6 months, the therapy is adjusted. Methotrexate being the first line of drug of choice, if contraindicated, that is, methotrexate causes hepatotoxicity. So if the patient is of CLT, we avoid methotrexate and we give sulfasalazine and lesinuromide instead. If the treatment targets is not achieved with conventional DMRDs, and the poor prognostic factors, and based on poor prognostic factors, that is the persistent disease activity despite conventional DMRDs, failure with 2 or more conventional DMRDs, high swollen joints, erosions on X-ray, and high ESR, CRP, anti-citrullinated protein antibody, and rheumatic factor. If they are absent, other conventional DMRDs are considered, and if they are present, biologicals or target synthetic DMRDs are added. After that, the patient was called up on follow-up, which Dr. Chatai.
So after 1 month of medical management, we have the patient back with us with a hemoglobin level of 9.3, and ESR and CRP also significantly reduced with the values of 52 and 28 respectively. Now, with a VAS score reduction from 9 to 6 and an Oxford knee score of 26/48, and the patient's markers improved significantly, we decided to operate on the patient and manage her surgically. And there are certain challenges that we face in these kinds of patients. The first one being what to operate first, the hip joint or the knee joint. So we decided to operate on the knees because deformity and pain of bilateral knees is more severe than the hip joint. So even though the literature recommends that we should operate on the hip joint first, but because in this patient specifically she had deformity in bilateral knees and she had a significant amount of pain and she did not report any kind of disabling pain in her hip joint, we decided to operate on the knees. The next question that arises is, if we are operating on the knees, should it be a unilateral total knee replacement or a bilateral total knee replacement? So because in the patient, bilateral knees would be operated simultaneously, because a unilateral TKR would pose problems in the post-operative rehabilitative process, because if only one knee is replaced, it would be difficult to do exercise measures and rehabilitative measures with the other knee still in a flexion deformity. The third question being the type of implant, should it be a cemented or uncemented implant? So the cemented implant was our choice of surgery because of the long-standing disease process in the patient. Her subchondral bone would be too weak to bear the mechanical stresses after the operation, and we would have a possible complication of the implant sinking into the bone after the operation. So a cemented implant was decided upon. The fourth one being pathological considerations. So with regards to the pathophysiological considerations, the bone quality had to be assessed for iatrogenic fractures, periprosthetic fractures, etc. Soft tissue assessment had to be done for ligaments like the MCL, the patellar tendon, MCL being the medial collateral ligament, etc. Because some degree of deformity is also corrected with the help of these ligaments after the operation. The fragile soft tissue would be a sequelae of long-standing disease and had to be taken care of. And bone deformities and supple joints would be another major complicating factor in this patient because precise cuts are needed for the prosthesis to function effectively after the procedure. The final question that arises is to either retain or sacrifice the posterior cruciate ligament. Now, in this topic, we have two schools of thought. So we have basically two surgeries that are available for total knee replacement. One is posterior stabilizing, that is PS surgery, and the other is cruciate retaining or CR surgery. Now, in this patient specifically, we can't opt for cruciate retaining or CR knees because the flexion deformity is more than 20 degrees in bilateral knees. So the posterior stabilizing, that is the PS knee prosthesis, provides stability and control to the movement of the knee joint. So in this, the plastic insert has a prominent post at the center that engages with a cam mechanism on the femoral component. So what this does is it prevents the knee from excessive backward movement, that is posterior instability. So it is chosen for patients with a weak or damaged PCL, that is a posterior cruciate ligament, as it compensates for the deficient ligament by providing additional instability. So this is the operative instrument that we use for total knee replacement.
Sorry to interrupt, senior faculty from Auto, can you decide on need for surgery and type of surgery without any cross-sectional imaging like CT or MRI? We just see plain X-rays.
Yes, sir. For certain severe deformity and severe arthritis, we did not need any kind of CT scan or MRI.
Another quick question, I think that could be supplement. We have looked at the bone workup. Bone quality by looking at the severity of osteoporosis, osteopenia with DEXA would have been helpful. Then how have we assessed the muscles and soft tissue? If the quadriceps are really atrophic, as was pointed out in the physical examination, what prognosis would you give following successful joint surgery of recovery of joint function? Would that not depend on the soft tissue and muscle components also?
Yes, sir. Definitely, soft tissue are as important as bones, and especially after joint replacement surgery, the importance of soft tissue is much higher because in such kind of patient who are having
instrumentation that we use for total knee replacement in the operation. So this is the femoral trial. These are the tibial base plates, and these are the plastic inserts facilitated by other instruments that are used to make the precise cuts and put the implants into place. So intraoperatively, total knee replacement is all about soft tissue balancing and alignment. So after epidural anesthesia, thorough preoperative planning was done to assess joint range of motion, laxity of ligaments, etc. to plan out soft tissue balancing. So as we can see, after the epidural anesthesia, the patient still has a flexion deformity which is not correctable. So this means that there is significant soft tissue contractures and ligament instability and laxity which needs to be corrected during the procedure. So the right knee had a 50 degrees of flexion deformity and the left knee had around 40 degrees of flexion deformity. So these are the some intraoperative pictures of the operation. Then you can see that the cartilage is completely worn out over the tibial and the femoral condyles. The cuts through measured resections and gap balancing techniques are done, and this is the intraop picture showing the placement of the prosthesis over the femoral condyle. This is the post-operative picture of the patient after the TKR. So as we can appreciate, These are bilaterally completely aligned knees after getting corrected with visible femoral and tibial components in place. The plastic insert is not visible on the X-rays. The implant that we used is of Zimmer, that is the next gen model, and the parts of the implant are the femoral component, the tibial component as shown here, and something that is not visible on the X-ray is the highly crossing polyethylene spacer. There are possible complications after the operation, the immediate being bleeding and venous thromboembolism, the early ones being infection, neural deficit and instability, and the late ones being implant loosening, periprosthetic fractures, bearing surface wear and implant failure. This is the post-op day 1 of the patient walking with the support of the walker. And as we can appreciate, the flexion deformity of the knees is significantly corrected. Flexion at the hip joints is also significantly corrected, and she does not have a stooping forward posture anymore. So this is a routine standard post-op rehab protocol in which we make the patient stand and walk with the support of walker the very next day after the surgery. So post-operatively, we assess the functional status of the patient. The Oxford knee score now being 40 by 48. Earlier it was 26 by 48, which signifies satisfactory joint function. For the post-operative medications, we gave her an antibiotic coverage of cefoperazone, sulbactam and amikacin along with calcium and vitamin D3 supplementations. We started DVT prophylaxis in the form of tablet rivaroxaban, 10 mg HS for 1 month, and treatment for osteoporosis was started 4 days later with injection teriparatide 20 micrograms subcutaneously for 3 months after loading the patient with calcium and vitamin D3. And for further rehabilitation, we took the help of the physical medicine and rehabilitation department, for which I'd like to call upon Dr. Pawan Sharma.
Good morning. I am Dr. Pawan, PG resident from Department of PMR. Post-op day 1 on examination, right hip had range of motion terminally reduced with power 3 by 5 in all quadrants. Bilateral quadriceps and hamstring power was 3 by 5. There was mild swelling present on bilateral knees and all peripheral pulses were palpable as well as toe movements were present. There was presence of swan neck and coronary deformity. So after total arthroplasty, this is the standard protocol which is followed, post-op rehabilitation protocol, the goal of which is to protect the reconstruction while steadily progressing towards maximizing functional potential. Each patient following reconstruction will progress at a different rate. Achieving the criteria of each phase should be emphasized more than the approximate duration. Ice packing 2 to 3 times a day for the first 2 weeks post-surgically. Full range of motion is critical to a full recovery. Our goal is 0 to 120 degrees of active range of motion. Minimum active range of motion should be 5 to 90 degrees by week 4. And if 0, that is knee straight, and 90 degrees, that is knee over toes, is not achieved by 6 weeks, then a patient would need manipulation under anesthesia. Full functional return without restrictions should occur at approximately 12 weeks, that is 4 months. Phase 1 is which is from day 0 to day 3. Goals are progressive reduction in swelling, passive range of motion 0 to 90 degrees to prevent post-operative stiffness, progress knee extension strength to equal to or more than 3 by 5, that is more than the anti-gravity strength, independent with ambulation using rolling walker or weight bearing as tolerated. Phase 2 starts from day 3 and extends up to 4 weeks post-operatively. Goals of this phase are progressive reduction in swelling, active range of motion 0 to 90 degrees, that is knee straight to knee over toes. Knee extension strength should be equal to or more than 4. Independent straight leg raise without extensor leg, and independent with ambulation using least restrictive devices. We planned slow rehabilitation with minimum risk strategy because this was a challenging case for us, as our patient was from a remote area where rehabilitation services were not present. Our patient did not fit in the standard DKR rehabilitation protocol because she also had osteoarthritis of right hip, which reduced the stability as well as proprioception. And after TKR, knee proprioception further reduced initially, due to which chances of fall increased, which may lead to fracture as well as polytrauma. On post-op day 1, she was advised standing with walker, low step walk with walker as you have seen in the previous video, range of motion. On day 2 and 3, isometric strengthening, range of motion, Russian current for bulk building of quadriceps and walking with walker. On day 4, along with the previous protocol, all these were explained before discharge. Proprioception enhancement, gait training, gentle knee posterior capsule stretching, joint protection technique, energy conservation technique, fall prevention technique, hip range of motion, isotonic strengthening, spine extensor, isometric strengthening, abdominal muscle strengthening as well as bilateral upper limb strengthening. Following splints are there for swan neck and water neck deformity, which are given. You can see on the left side is a ovalate finger splint, on the right side is silver ring finger splint. We prescribed this one, single armchair finger splint, and this one is the most prescribed one. Future plan on next visit, shift from phase 2 to phase 3 of TKR rehabilitation, osteoarthritis of right hip management, medical management of rheumatoid arthritis, as well as deformity prevention and further management. I would like to call Dr. Shatayu to take the case forward.
But the story does not end here. After 15 days, the patient presented with a sudden onset of pain in left knee after a history of fall. Now, on examining the patient in the OPD, on the left knee we have swelling, tenderness and crepitus present and painful range of motion, while the right knee examination was normal. So we requested bilateral knee X-rays for AP and lateral views. What do you think could be the possible cause of this pain?
Synovial fluid होगा क्या after replacement? It is replaced by the last.
नहीं सर, synovial पूरा हटा देते सर, posterior synovium entire.
What I am saying, synovial surgery.
It is much lesser of a possibility, sir.
It again gives a
Replacement.
It is difficult to complete removal of the synovium. There are some remnants and it will regenerate after some time. So there are chances of synovial effusion, hemarthrosis, there are chances of blood collection or
the artificial joint is also lined by a synovial line. So in your slide you had told post-op complications, immediate, early and late. So can you just repeat what are the early complications?
So bleeding and venous thromboembolism, sir. These are the early complications. So when we got the X-rays back, this is what we see. Now such X-rays after only 2 weeks of replacement surgeries are very, very scary for the operating surgeon. So what we can appreciate here is a periprosthetic fracture of the distal end of the left femur with a stable implant as seen on the X-ray and a spinal fracture on the distal femur. So this is the CT that we requested for left knee with 3D reconstruction, and with it we can better appreciate the kind of fracture that has occurred. Now the question arises, how do we manage this fracture? So for this, we have a Lewis and Rorabeck classification of periprosthetic fractures proximal to total knee arthroplasty. So what we have here with us is a type 2 displaced fracture with an intact prosthesis. So the treatment algorithm for these kinds of fracture are, it is a supracondylar periprosthetic fracture with a stable prosthesis and a displaced bone. So the bone quality in this patient, as we have discussed, is poor. So what we plan for is an open reduction internal fixation with a distal femoral locking compression plate, better known as a DFLCP. So for pre-operative planning, we considered the following factors. We checked for the stability of the implant clinically on X-rays and CT scan with 3D reconstruction of the left knee. The implant was found to be stable, but still for our safety, we had a revision total knee replacement implants ready. And the plan was to ultimately restore the anatomy of the distal femur with a distal femoral locking compression plate. And this was the post-op X-ray of the patient. So the post-operative status, the patient was mobilized in bed the very next day after the operation and was made to walk after 6 weeks with the help of a walker. Calcium and vitamin D3 supplements were given and the patient was taught exercises and strict adherence to the exercise regime was explained. This is the pre-operative photo of the patient and this is the 2-month follow-up of the patient after the DFLCP operation. This from the sides. Yes, sir. these are the comparative walking videos of the patient. These are the pre-op walking videos, and that is the post-operatively after 2 months walking video of the patient. That is after the operation for the periprosthetic fracture. So, for the take-home message, we are that rheumatoid arthritis can be a seriously disabling condition if left undiagnosed and untreated on time. Patient counseling regarding the disease progression and its complications is of utmost importance. Regular medications increase longevity and mitigate such risks. Rehabilitative measures play a significant role with medical management. Interdepartmental communication is a must for patient benefit. And ultimately, leaving such a serious illness undiagnosed or untreated is no less than a criminal offense on part of the patient, the family, and the practitioner. So, I'd like to convey my thanks to our hospital management, Department of Medicine, Radiodiagnosis, Physical Medicine and Rehabilitation, Department of Anesthesia, the CCR Review Committee, patient and family members, and of course the Department of Orthopedics. Thank you.
6 swab kidney transplant in a single day. So 6 kidney transplant in a single day was first in Rajasthan and second in the country after Indore. This is what Dr. Suraj Budara has told me. So similarly, your work should also be publicized. But at the same time, there are some unfortunate things are happening. The medical negligences are there. So one need to be very careful. From the Department of Anesthesia, Department of Surgery, main surgeon who is operating, residents, that and instrumentation type of will show that there is nothing wrong done with the patient. It is not good for the patient, it is not good for the doctors operating, not good for the institution, and be very careful. We'll come out with some strict measure also in the future, but we need to be very, very careful. You are doing good work is all right, wonderful work is all right, but one wrong thing can spoil whole image of the doctors and the institution. So be very, very careful in the future whenever you are doing major surgery, especially operating on the cavities like laparotomy, cesarean sections. Thank you.